Hello and welcome to today's webinar, Future-Proof Your HEDIS Strategy, Simplifying Quality and Risk Management. Before we get started, I'd like to review a few brief housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the handout section at the bottom of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you are having trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen. We're very fortunate to have with us today Brad Wilson and Jeffrey Springer. Brad Wilson served as President and CEO of Blue Cross Blue Shield of North Carolina for almost 8 years, capping a 22-year career with North Carolina's largest health insurer. Under his leadership, BCBSNC grew to a $9 billion company serving over 3.8 million customers. Brad holds a BA degree from Appalachian State University, an MA degree from Duke University, and a law degree from Wake Forest University. Jeffrey Springer is Senior Vice President of Product Management for CityTech. He has more than 20 years of healthcare industry experience and is credited with founding the first payer-provider contract management company in the U.S. Jeff holds a mechanical engineering degree and an MBA from the Wharton School of Business at the University of Pennsylvania, where he graduated as a Palmer Scholar in the top 5% of his class. At this time, I'd like to turn the floor over to Brad.
Well, good morning, everyone, and I'd like to thank everyone for participating this morning, and Jeff and I certainly hope that you will find at the end that this is a good use of your time on a very important subject. So I'm privileged to be with you and offer some comments and insights about our topic. As we begin by looking at slide 3, our objectives, I'd like to open with just a couple of general comments as we begin to click through our agenda. I think we all recognize that the proposed changes to the existing measures, and in particular the new measures, are going to likely impact changes in input specifications across our organization on the mantle of capturing new data elements, and thereby close attention to detail and precise and accurate data capture is going to be extraordinarily important. And I think as we go through our conversation today, you will be able to recognize the wisdom of this kind of opening comment. So as we begin to think about this, I would suggest that the ultimate goal should be for all of us to execute these changes efficiently across every dimension of our organization, such that the result is a positively transforming event that highly impacts quality management capability to the end that it becomes essentially a core competency and thereby a competitive advantage to our organizations in the marketplace. I would also like to suggest that as provider partners focus on their HEDIS performance, that organizations that are in a position to be an informed, engaged, and productive partner with them to help them maximize their care efforts on behalf of their patients is an important partnership attribute. That in that partnership relationship, as in particular payers and providers work more closely together to increase quality and lower cost, that demonstrating a capacity and a capability, an ability and a willingness actually to partner with your providers and help them be successful is an important byproduct of the technical work that is necessary to do that which we are going to discuss today. So as you look at our objectives, I would also offer that to the extent that you need more incentive to energize your focus on efforts to positively impact and enhance your member engagement initiatives and your provider partnerships, the NCQA HEDIS changes should help with that incentive. We all recognize that strong performance against HEDIS measures is a statement about not only your competency, but your commitment to ensuring higher quality care to your members and to patients. I would also urge you to view this work around embracing the HEDIS changes as not just another compliance task. My experience is that when things from the outside come inside, that frequently an attitude can develop that we're being made to do this, and that it is, yes, another item on the compliance checklist. And I don't believe that that's a healthy attitude in general, and I certainly do not believe in this circumstance. So I would urge us to look at this as an opportunity to align business and technology strategies, to unify your vision efforts for higher quality and lower cost, and to make sure that you take an enterprise view of your HEDIS work to optimize coordination, execution, and certainly execution of quality, risk, and value-based initiatives. I think central and key to all of this is the point that we're talking about alignment of people, process, and technology. So you can see our agenda for the day. I'm going to focus on understanding the need for coordination, and then we'll hand off to Jeff for discussion on the other agenda items. So as we look at slide number 5, quality and cost conundrum, I view this as a visualization that underscores the 3 foundational concepts of healthcare, which are probably obvious to everyone that's participating this morning. Access, quality, and cost, because it's a glaring statement of the obvious that access, which means that people have timely opportunity to avail themselves of the right resources based on their particular circumstance. And as they access the healthcare system, they certainly want and deserve the highest quality, that is the right care, at the right time in the right place, that ultimately will yield the highest value at the best cost. Cost being simply, for me at least, a component of that very important term of value. It's not about cheap. It's about the best quality care at the most efficient cost for the application of that care. Now, what can very easily get in the way, you see listed there on the slide. We all have in our organizations competing priorities. Mandates must be done. Regulatory compliance, there's no choice about that. We all have infrastructure projects, upgrades, new software development, retooling of systems for the changing value-based care landscape that compete for resources and time and attention. We all have project work that may be narrowly focused on 1 or 2 components of our capacity and capability. And all of this together puts a strain on IT and human resources that sometimes causes us to sub-optimize our particular efforts. So we tried to capture 3 or 4 summary points, one in particular, the challenge to manage more than one variable via a single initiative. We all struggle with that, and those things can certainly get in the way of access, quality, and cost. Patient outcomes, that is also a goal that all of the players in the healthcare ecosystem aspire to achieve in every activity. I think that as you examine this slide, the components around the core triangle, I would suggest that we must remain laser focused on the patient, always striving for better outcomes. And what we wanted to show here is a depiction of that which I'm sure you already know, that delivering high quality care and delivering the best value is a multidimensional task. And to the extent that synchronization and alignment is not achieved as we focus on these various ingredients, and to the extent that optimal quality is not delivered through these efforts, by definition, value and positive patient impact will be diminished. Therefore, it is critically important that strategic thinking, as you think about your HEDIS deployment, be undertaken to coordinate and align to the extent humanly possible all of the activities that are occurring under each of these particular activities. And slide 7 gives you a snapshot of all of the moving parts of organizational initiatives across 5 important dimensions. And I believe that really understanding at a granular level, to the extent that that's possible, the relationships between all that you see here, all of these moving parts, and pairing information management with comprehensive analytical capabilities will yield the higher quality care that we are all striving for, and hence optimize the HEDIS scoring opportunity. Turning our attention to slide 8, this is a depiction of what we believe and would suggest, and Jeff and I have discussed this at great length, of what it should look like. This is what slide 7 should be. A unified view where the quality and cost efforts are universally understood, the project work is aligned, accountability is clear, and doing that well will yield a comprehensive 360 patient and provider view of cost and quality through the HEDIS metrics. And then as we look at slide 9, I would suggest that this is a summary, again, of that which we all know very well, but for some reason we always need to remind ourselves. The goal needs to be a comprehensive assessment of what it is that we are trying to achieve at all of the various levels. And I would suggest that focus and clear understanding and refreshing our commitment to these goals are particularly important in a turbulent and rapidly changing environment that, quite frankly, is the norm in healthcare today. So I look forward as our conversation continues, and hopefully we'll get some of your questions a little later. So Jeff, I'm going to turn it over to you now.
Thanks, Brad. As we transition into from that top level picture that Brad laid out into what's changing with HEDIS, with NCQA, some of the things that Brad pointed out are definitely coming through in terms of what NCQA is doing. So NCQA recognizes this conundrum that Brad talked about, this quality cost access conundrum, and are making some fairly significant changes to the programs that they're doing in order to make some of those things easier, faster, better. And in terms of coordinating across those different groups, I'll talk a little bit about the 4 categories of changes that NCQA is making. If you've attended any of the NCQA webinars, these concepts should have come through for them, but I'll highlight these in terms of what do we see those impacts are on the overall payer and how you should think about them, not just related to HEDIS, but related to all those programs that Brad talked about, and how you can take that and really drive better engagement with your providers, your members, and all of your internal folks. So the 4 broad categories that we have here are flexibility, allowable adjustments. And we'll go into each of these in more detail, but I'll take a minute to talk about each one of these here before we go into more detail. So allowable adjustments really answers the question of, can I use clinical data or other types of data in my measures? How do I adjust my data for a value-based contract, for year-round chase, for a population health agreement? So all of those other programs that Brad talked about try to leverage measures. A lot of them leverage the HEDIS measures in various ways. Allowable adjustments allows you to leverage the same measures for those other programs. Let's talk about access for a second. So if you talk to a provider about how much time they have to see a patient, they have 15 minutes to see a patient. They want to spend almost no time looking at their computer. They want to spend all their time talking to a patient. Now, when they go and document that visit, and then that visit gets codified, and then that visit gets used, one of the problems that we have in HEDIS is, did we get the right data? The allowable adjustments allow us to leverage different types of data for the same types of questions. And this is a very powerful thing for coordinating across programs, but also allowing for simple things like access. And you would think access is not really related to HEDIS, but ease of use, simplicity, operational efficiency drives things like access. Quality costs are more clear from the HEDIS perspective, but things like that are also operationally focused. Time, this is another one where we have definitive questions on how to use our HEDIS measures. So HEDIS has historically been a retrospective program. We call 2 phases of HEDIS, retrospective and prospective. I would probably refer to it as glacial and retrospective in nature, because everything is from yesterday's rules. Even plans try to adjust the rules for what they might look like next year. For the first time, NCQA is going to give us rules ahead of time, which is going to be incredibly important. Number 3, transparency and ECDS. So ECDS, and we'll talk about this in more detail later, are drastically changing the way the rules are calculated. But I'll talk about the transparency piece here in terms of driving improvement is very important for creating competition. Meaningful Use did this on the provider side, and it definitely saw an uptick in competition and therefore improvement from providers. The transparency here will be clearer as people have choices, pick health plans, pick providers. The transparency of who's doing the job will be very important. And then from a licensing perspective, NCQA is definitively bringing these programs together, and you'll see how that's done. Now, with this said, we wanted to interject some of the audience involvement in here. So we've prepared a few polling questions just to keep your attention, and your polling question should now pop up. And as you go and look at this question, it should be on your screen now. We've clearly added some humor. I'm hoping nobody answers number 5 to this question. But would like to understand how your HEDIS season is going so we can understand that. And as I do that, I'll let you guys answer that. I'll go to our first section here of allowable adjustments, and then we'll look at the answer to your question. So allowable adjustments, I talked a little bit about this, but these really are taking the HEDIS rules and leveraging them for different programs. So Brad talked about the multitude of different programs that are out there. If these programs are using exactly the same rule, that's great, but you can't use exactly the same rules. They have to be adjusted somewhat to use them for a value program, a pop health program, contractual initiatives, so on and so forth. Allowable adjustments gives us the guidance to do that and allows us to calculate these rules differently based on what providers are able to do. So using clinical data, for instance, instead, using eligibility criteria that's different, using dates that are different, or some of the easy, quick examples of how we can do this. And really, as we start to try to unify these programs, this is one thing that's an absolute minimum mandatory piece of doing that to enable that coordination. So as we finish that, I'm going to finish the poll and publish our answers here. And it looks like large majority of the audience is actually doing fairly well with HEDIS. So, I talk about an 80-20 rule. We'll call this a 70-30 rule. 70% of you are seeing things going on track. 30% of you are at best skeptical. And so it's interesting, that's good. As we look at the overall rates in terms of health plans out there, I would say more than 30% of plans are less than 4 stars, which is what people typically aim for. So hopefully those 70% here are aiming at the 4 stars. So that gives us a little bit of a view into our audience and how you're doing. I'm very happy that nobody answered to number 5, but a little disappointed in terms of nobody is actually exceeding your targets either, because that's really where we would like people to be. And if you're not exceeding your targets now, it's going to be a lot harder next year. And Brad talked about the coordination there. That's really how you start to exceed your targets. Now, another way you start to exceed your targets is getting out in front of it. And the schedule changes that NCQA is going to give us the opportunity to get out in front of this for the first time for real. But you've got to be ready for this. So what are these schedule changes? So typically, the measures are released in July. The vendors take till January to certify. This year, it's been, almost to the end of March. February, we are certified. NCQA is going to announce everybody is certified on March 1st. But if you're certified now for measures that were for the reporting year of 2019, it's already too late to influence the behavior. What NCQA is doing is they're releasing next year not just reporting year 2020, but reporting year 2021, so that we can get a full year out and know what explicitly the rules are going to be for 2021 before the year even starts. And this is great. This means that for other programs, value-based programs, pop health programs, we're going to be using the actual rules that are going to be out there. But this means you have to think differently about them, use those rules across your organization. The next area that I'll talk about is ECDS and transparency. So I talked a little bit about transparency in the opening, but let me talk about ECDS and what it changes, because this is fascinating. So, we're clearly a vendor. I represent CityTech, the vendor. We're the only folks that are certified on both payer and provider. Where ECDS comes from is actually from meaningful use. We notice we're certified on meaningful use, the only vendor certified both meaningful use and HEDIS. What this is meant to do is to simplify the data capture, ECDS rules. How does it do that? It requires structured data that you can then use, capture, and calculate within your measures. The other interesting things that HEDIS has done that meaningful use didn't around ECDS is 2 things. One is, even if you're going to calculate the denominator and a member's not compliant on the denominator, you still calculate the numerator. Why is this interesting? So from a codification perspective, people don't always codify the things in the denominator, but they might codify the things in the numerator. So, hey, the patient has had an HbA1c test, but they're not diabetic. That's interesting. Why would that happen? In the ECDS rules, you're going to get the fact that they had that test, what the results are, even if they weren't compliant for the denominator. So that's a very interesting change, and you can use that from an outreach, pop health, value-based perspective, and that's very helpful. The other thing that ECDS does is it starts to use clinical data in the denominator calculation itself. So in HEDIS, previously we only used claims for the denominator. Now using that structured clinical data for the denominator actually as the primary source. So if we have clinical data that is the primary source of your denominator calculations, then you're using that data. And the transparency of that data, the use of that data, wanting payers and providers to share data more is what comes through from an ECDS perspective. Now, looking at this could drastically change how people calculate measures, how people use measures. But in addition, they're starting to say, we're going to start publishing the results of the ECDS transparently out to the public. Meaningful use did this. CMS, which is slightly different than NCQA, but similar thought patterns, followed a very distinct pattern of publish a rule, then compare how people did on a rule, and then pay differently based on that rule. And so it's very interesting to see if NCQA follows that pattern. They're starting to have people view those transparently, but we'll see we'll see how that goes. Now with that, I'm going to start our second poll question, which probably should have started after the last question, but maybe a little better late than never, haha, because it's a time question. One, are you aware of the changes from the timing of HEDIS? And then are you also thinking about how to leverage that? So that the question doesn't say that, but I think that's also implied in the question here. So as we do that, I'm going to go on to my next slide. Licensing. So the licensing for HEDIS and the certification for HEDIS has changed. So they're now incorporating a whole bunch of different things in terms of their standards and guidelines. You can see here that there's licensing for HEDIS around your pop health programs. That's interesting. So this is something that they're starting to force that coordination. There's stuff around your network management, i.e. your value-based contracting initiatives. There's stuff around utilization management, which then coordinates with cost and quality together. So they're starting to say, yes, we want you to use these measures across programs. We want these measures to be available across programs. But now in our HEDIS certification, we're going to now talk about these other programs explicitly and measure you on those programs. And as they do that, they're really trying to pull you together to view quality, cost, risk all together. Now with that, I'll publish the results from our question number 2, and we'll look at that. So here we see that for question 2, I think I published it. There we go. We see 66% of the people are aware of the changes that are coming from a timing perspective, and 34% are not. And so this is interesting from the perspective of, if you're not aware of these, I would definitely read up on them. I would definitely get prepared for them, because your entire organization should be leveraging these for more aggressive outreach programs ahead of time to use these types of rules. So that said, I'm going to publish our last HEDIS-specific question here. Of these changes that we just talked about, allowable adjustments, scheduling, ECDS, accreditation, which of these do you think is going to be most disruptive to you? And we have a I don't know question down at the bottom, which is also interesting from the perspective of we might not have established strategies around these as well. So as you answer that last question, we'll go on to the next step of what's the synergies that Brad was pointing out, that NCQA was pointing out between programs. So if we think about allowable adjustments, measures coming early, use of clinical data, really they're all trying to drive to a unified approach on quality that Brad was talking about. Can we create a single provider scorecard? Can we create a single member engagement strategy? How do we educate all at once? So when you're doing outreach to the providers, are you doing that for HEDIS? Are you doing that for a value-based care program, a pop health program, or are you doing it for your health plan as a whole? So as the health plan, I'm going to talk to you, Mr. and Ms. Provider, about all of these different things. So here's your measures for HEDIS, here's your risk categories, here's your value-based, so on and so forth. Single scorecard, lower that abrasion with providers, speak with one voice. That allows you to then have one voice for each of these programs. Now, these programs might still be separate departments, might be separate groups that manage, that drive them, but the outreach, the coordination should certainly be done once, not various times. And this is how you really create the partnership. And as you can do that outreach once, do you start to get into not just collection retrospectively, but prospectively? What does that mean is integrating standard supplemental data, and NCQA is making changes to that program as well. but then it becomes more proactive in nature and coordinated across those things. So as we look at that, I'll publish the results for our third polling question. Here we have actually a fairly even split of the programs that are out there. ECDS actually was the one that was most disruptive. We snuck FHIR in there. We'll talk a little bit about FHIR later. And the I don't know was the most popular answer of all of them. This speaks to me that the changes are not yet well understood, and people are probably focused on HEDIS season, not on the strategy that comes next, which is understandable, but I would start to get to that strategy fairly quickly, because with these changes, NCQA is going to force us to think differently, and from a competitive standpoint, which Brad talked about, quality, risk, operational efficiency around these things are really going to be a differentiator going into the future, and these are all meant to drive towards those things. All right, so as we look at these things, so this is a similar slide to what Brad showed before, but what HEDIS NCQA is really trying to do is be foundational to all of these other programs, to your risk programs, your value-based programs, pop healthcare management, leveraging these measures across those things, leveraging the outreach once, not multiple times. In the industry today, I see folks using 2, 3, 4, 5 tools, as the slide that Brad showed. How confusing is that for any end user to figure out where the provider is, where the member is, if they've got to go to 5 different tools to see that? Really with the goal of driving down cost, improving quality, improving provider engagement and member coordination. And really that foundational component that HEDIS is doing and driving towards is going to change the way we think about it. It's going to make the quality groups of all these things really the driver of health plan success as we become more value-based, and I can't see how we can't become more value-based going into the future. These teams become more important, the collaboration, coordination of those become more important, and this picture is really what NCQA is driving towards, what strategic health plans are driving towards, as Brad talked about as well. How do we view this at CityTech is really in sort of layers, or here concentric circles. So as you think about your programs, you have to first think about regulatory compliance. So clearly HEDIS is a program with a lot of regulations. So you've got regulatory compliance around sampling, measures, submission, how do you do your medical record review, so on and so forth. So that's the center of the circle, that's the base of Maslow's pyramid. But as you expand past there, how do you do prospective? In the world of tomorrow where measures are going to come earlier, in the world of tomorrow where you have allowable adjustments, you have transparency on those things, you can use different data. Prospective could look very different than it does today, where you're just chasing charts the same way you're chasing charts in retrospective, but for a different population, water population. Then as you expand the next level out, it's beyond HEDIS, various programs. So clearly the regulatory program, STAR, risk, but your value-based contracts, custom measures, custom chases, how do you coordinate with one voice across your organization? And then really, how do you create an integrated performance management platform, pulling in data? So as we get to FHIR, which is coming next year, or maybe even later this year from NCQA, how do you really pull in data from that perspective? And thinking about these things is not a yes-no question, we'll get into this in a minute, is a matter of maturity. And you could be on the left side of the maturity curve or the right side of the maturity curve or halfway up it. And so we'll talk about that. And how do you modernize your HEDIS program? And so as we think about this maturity, we think about it in sort of 3 buckets. You have a coordination problem. How well are you coordinating? Are you coordinating with a provider per campaign? So I've got a campaign for a specific measure. So, hey, I want to coordinate for my COL measure, outreach to providers. Are you coordinating across campaigns? Are you coordinating across programs? Are you coordinating early enough with providers? So as you get more and more mature, here is a single contact for your provider engagement. Your providers are proactively engaged around those things. Time and data problems. So do you get the data to be able to use it and leverage it proactively? So historically, the HEDIS tools have updated your data quarterly, monthly. We're starting to see some do it more frequently than that. We work with our customers to do it weekly, if not daily, that's out there. As we start to get to more and more ECDS measures, you want to process that data faster. The coordination with providers, I can see the transparency getting to the point where providers are interacting directly based on the data that they're sending, and the time and data problem around that. You certainly don't want to go to a provider and say, hey, you have a gap, and they can say, I saw the patient yesterday or last week, and you're not knowing about that. And then the focus problem. And this takes an organizational alignment of how do you coordinate across these programs? How do you use this? This is a people, process, and technology question from a scorecarding perspective, from a communication perspective. How do you train your folks to do outreach across these programs? Typically, people are trained in one program or even a subset of measures, maybe in the provider demographic. How do you do this coordination focus across things is going to be important. So as we look at each of these problems, from the coordination perspective, I'll start with the left hand of this slide, is looking at provider performance, member adherence, and really looking at it across all of your programs, collecting the data, driving the workflows from a single spot so you can make sure you understand where that provider performance is across the different programs, and making sure you understand how providers are being measured. So member-provider attribution is incredibly important as you talk about prospective campaigns. So in a retrospective campaign, you're looking at where did care occur. In a prospective campaign, you're starting to look at where care should occur, and then trying to drive who should walk in through the door. And this is a typical population health question of who should come in. Now it's going to become a HEDIS question, a risk question, and then what does that provider have to do across all these different programs, and then what data is available to those folks today. And so this requires a data strategy, a coordination, workflow strategy, and then an outreach communication strategy to really drive this coordination communication. From the time date question, it's really being able to pull data in and process it more quickly. So being able to scale with that data, how do you create faster throughput, not just of the claims data, but all the standard supplemental data, even the non-standard supplemental chart abstracted data to understand what its impact is across all these things. So being able to load those rules, run them quickly, provide feedback scorecards to providers that are meaningful based on where they are today. If I'm going to give a scorecard to a provider that shows a member's out of compliance from last month's run of that data, that provider will lose trust and credibility in that, and basically do their job the way that we're going to do their job anyway. If I'm going to provide them a view of here's what's real as of today based on the data that I have, then they start to use that operationally to drive their initiatives going forward. We see the most successful plans coordinating very closely with providers, driving the outreach to those providers, and then providers doing self-service on those scorecards because they trust the data on who do they need to reach out to, what gaps do they need to close. Very important there. And then the focus problem. So the three categories here: organizational commitment. This starts at the top. How do these programs coordinate? How do these programs share data, not just within the programs, but with providers? How do you do outreach to those providers? When do you do outreach? The timing of this outreach starts maybe with a contract even. Then you have when do pop health programs reach out to folks to say these are when you engage. How do you collect data from those providers in a standard supplemental way? So all of these coordinations have to be strategic in nature. It can't be, oh, we're in HEDIS season and now it's time to reach out to Dr. Jones, or community IPA group 1, 2, 3. So starting to have those conversations with providers, here's all the things we're measuring you around, here's how we'll communicate to you, here's how you can drive those initiatives becomes incredibly important. I think about this as an analogy with banking, so bear with me for a second. My very first check that I got, somebody handed me the check. I walked across the street. I waited in line at a teller. I deposited my check. I was very excited. I can't tell you today the last time I touched cash. I don't see my checks ever, my paychecks ever. If somebody does give me a check, I can take a picture of it with my iPhone and deposit it. HEDIS, our coordination with providers, is still walking across the street to the teller waiting in line. We are not even close to that. I'm going to take a picture with my app to deposit that check. We have a lot of improvement that we can do here, and this takes organizational commitment to get to that level. Before we do this last slide, I'm going to publish our last polling question. So our last polling question is getting to really a strategic question of readiness for fire. So as we think about changes to how you're doing your programs, really the next big change that NCQA is looking at is fire. How do we use fire? How do we leverage fire within our organizations? Clearly, we have a joke in the first question of we don't know how to spell fire, spelled incorrectly for the healthcare versions. And if you don't know what fire is, you can answer yes to that. The use of fire could drastically change the way we coordinate with our providers, how we collect data from our providers, how we share that data and improve our measure scores, basically taking out the question of chase altogether. And I think that this is really the end game. This is that take a picture of a check you just had and deposit it automatically, no more tellers, no more lines, so on and so forth. So as we wait for those results to come in, I'll go back to our slides. I'll talk about one of our customers' experiences in terms of their improvement in their outcomes. This particular plan's improved 1.5 stars using our tools. I can't take credit for all 1.5 stars using our tools. There was a ton of people and process stuff that they did well. They engaged with their providers proactively. They created single scorecards across their organization. Previously, they had 5 groups reaching out to providers. They unified that to have one group. They reached out ahead of HEDIS season, long ahead of HEDIS season, to drive that coordination and communication. And they also wrapped in value-based measures, pop health measures into those initiatives and really drove single scorecards out from there. Seeing huge improvement. You can see some of the measure improvement here from a tactical perspective. The biggest number, though, is that 1.5 star improvement is absolutely huge if you think about that. And that's the type of improvement that we think all health plans could have if they think about this strategically. So I'll publish the last question we had. From the fire perspective, there's a clear winner here that people haven't really started to look at this yet. Probably don't know a lot of information around this. NCQA actually just had a webinar 2 days ago around this and what they're doing. So some interesting upcoming stuff for this. There are some folks that probably don't even know what fire is. So we see some people answering the first question. They're a small subset. There are a few folks who are actually prepared. This is great. I know that there are some health plans that are actively building fire interfaces into their things to move data in and out. But this is really where I see healthcare moving, is towards this end. So with that, that brings us to, I do have to do the 10-second advertisement on who is CityTech, so some of you might not have heard of who we are. We're a 100% healthcare company. We're 4,000 people, over $2 million in revenue. We're a product and service company. As Catherine introduced me, I'm the leader of the product side, but we have a huge services business. The way we view this is we want to make sure your solutions work for your strategy, both business and technical. So integrating a HEDIS solution into your organization, as we talked about for pop health, for value-based care, for risk, takes integration to a number of things, both business and technical, and that's the way we think about it. So having a single chart management solution, having a single outreach solution, a single faxing solution, a single document management solution, those are some of the technical things. From the business perspective, driving single scorecards, outreach, so on and so forth. That's the way we think about making our customers successful, and our first question is, what is your business strategy, what is your technical strategy, and how do we enable that? So with that, brings us to the end of the webinar. I hope you enjoyed the prepared portion of this. We have some time for some questions. So Catherine, if we've gotten any questions, or if you want to add questions now, we're happy to take those.
And Jeff, if I could, I'm sorry. Sorry to run over you there, but if it's okay, I'd like to make just one closing overarching point that I think, Jeff, you did a great job throughout your narrative creating this melody, and I hope I want to make sure it's not lost on everyone. And I alluded to it in my opening remarks. Compliance. I know we have a lot of leaders on this call that will not only be doing the heavy lifting and the deployment and the tactical work that's necessary to accomplish the task, but will also build the attitude and the culture around the execution. And I would just suggest that the more that we can all think about the new HEDIS rules that we will all want to comply with as a mandate or regulatory compliance initiative, to the extent that we can bring an innovative and entrepreneurial attitude and spirit around that, will then yield the type of results that Jeff was able to show us near the end of the presentation. In other words, everyone who is in this space is going to do it. The question is, who's going to do it better and more effectively and sooner, and with again, an innovative attitude and spirit that can then yield higher quality, lower cost, and become a competitive advantage for you in the marketplace. So I would simply close by saying attitude is important, and talking about and thinking about this initiative internally in your organization as an opportunity to differentiate your organization and impact patient care in a positive way, I think not only makes the journey easier, but will yield greater results for you and your teams and your organization. Sorry, thank you.
Certainly, and now at this time, we'll take some questions that came in during the presentation. Our first question is, and Jeff, I think this is for you. I know you said we should prioritize HEDIS 2021 strategy. If you had to identify an approximate timeline, when would it be? Mid-March and April?
Yeah, so I would break this question probably into two parts. So for the 2021 strategy, the measures for that won't be out until August of this year. And so we won't know explicitly what are the things we want to measure, how we want to measure, but there are some things that you can start to do even right now that I would start to look to do. And the question becomes, how are you going to leverage these measures when they come out? How are you going to include those in your value-based contracts? How are you going to drive your pop health programs? How are you going to coordinate with providers? As Brad talked about, this strategic focus of quality at the top level are important questions that you need to answer before you ever get to the measures. Once those measures come out, then it becomes more tactical around the measures themselves and rolling them into those programs. But if you don't have the strategy of how you're going to use them across the programs, then now is the right time. So you could definitely start looking at that when HEDIS season calms down a little bit, but it's going to take organizationally not just your HEDIS folks, it's going to take your pop health folks, your value-based folks, so on and so forth. And then provider relations or provider outreach becomes incredibly important. When do you want to start to do that? How do you want to start to do that? So those are the questions, and you saw the different components of the maturity model, looking at it from that perspective. And if you're interested, we can go down multiple levels on that maturity model to talk about the types of things that I would focus on now. Clearly, the measures won't be out until later in the year. But if you're waiting for the measures to come out, it's too late to start to think strategically about how do you execute on those differently. Great question.
All right, our next question is, one of the biggest challenges due to the complexity of HEDIS technical specifications is how to respond to auditor to state questions on why a member is not in a HEDIS measure.
Yeah, that's always been a tough question. I'll take that one as well. So we didn't talk about this in our presentation itself, but we have a tool we call Audit 360, which gives transparency of the why a member is in or not in a particular measure. This is a very important question. So the questioner asked about auditors in particular, but I would expand the question to ad hoc audits. So providers ask questions, care managers ask questions, pop health folks ask questions, so internal and external ad hoc questions of, hey, I think John Doe should be in this measure, why is he not? I think Jane Smith should not be in this measure, why is she in this? And getting the transparency to understand, here's how that member processed and why they processed that way. Typically those answers in systems that I had previously been a part of at other companies would take months to answer, and I think those questions do take a long time to answer. With our tooling, where you can see the transparency of how a member processed against those answers can take minutes, if not maybe days, depending on the complexity of the data that's out there. But very important to be able to answer those, and people love to see that because it's in an English language version, even though the measures are very much codified out there, to see the why behind that.
Next question is, I frequently get questions from our C-suite about why measurement go up or down one year to another. One unknown is the impact of measure spec changes. Is there an easy way to see the impact of spec changes?
So is there an easy way? Probably not. The way that we view this is similar to that audit function. We can process a member against a measure this year and a measure last year, same member, same data, and we can show you the difference at a detail level of why they process one way or another. That visual capability isn't the actual NCQA spec change, which is in English, but it's our configuration of that rule, and the transparency in viewing that is the why behind that. And so that's the way we help our customers to do that. And it's really, a proxy for the way the NCQA wrote that, but it's a very good proxy for people to see how that processing occurred at that member level for that change. So, hey, I added a change of value set. I can see these members are in this year and they weren't in last year. I can see it was specifically due to this value set as an example, or this other change that was out there. And so we give our customers the ability to see that transparency, but the actual specs themselves are translated into our tooling to do that. And that's something that we do, I think, very well around that.
Next up, my network has more than 10 different EHRs at play. How do we manage data from so many systems? All
right, so this answer will change as we go forward into the future. So we talked a little bit about FHIR. FHIR interfaces could potentially pull data in different ways. Today, people are collecting supplemental data in different ways. So standard supplemental, you're collecting directly from the EHRs, and you can get that. The auditor would then have to approve those sources, and then you can leverage it that way. There's new NCQA regulations that are enabling you to have certified solutions around collecting standard supplemental data, which is very powerful. It's moving towards the ability to standardize that. And so NCQA is pushing more and more towards standardized data as we get towards ECDS measures, which were the one area that people highlighted as most important. Data collection will become more and more important. And NCQA is making a number of changes with FHIR, with standard supplemental certifications of data to drive that in a more standardized way, which will be very good and very important. From our solutions perspective, slightly different in that, you have to be able to manage, transform, process that data, and use it easily within the measures, and then run the rules against those to see the impact of each of those. Some of the standard supplemental data impact reports can show that, but that's standard HEDIS functionality as well. But this question will become more and more important, and NCQA is making a number of changes to drive things differently there.
Thank you. Next question, related to value-based care and population health, where has FHIR integrated significantly?
Significantly. So I would say we're probably not there yet. I think that this is a promise of tomorrow that people see, not a value of yesterday, which we've already measured. But I think that there is a ton of promise in FHIR, otherwise known as FHIR interfaces, to pull data in a standardized way to leverage them. We're seeing more and more health plans leverage these. NCQA is coming out later this year with sample FHIR measures, and then in 2022 with official FHIR measures. So I don't think we've yet gotten to the tipping point where we're measuring, hey, here's the improvement from FHIR. This is very much something that's coming, though, and something to watch because regulatory-wise it's being pushed, and then strategically it's being pushed within health plans as well. One note on FHIR, FHIR can be used for the specific measures as NCQA is doing, but once you have those FHIR interfaces, you can set up a whole bunch of different applications and talked about the taking pictures of the checks. Things like that, creative uses of this data is way easier using FHIR than it's ever been before. So Brad talked about the innovation that we have to drive, the entrepreneurship we have to drive. FHIR really enables that in a way we haven't seen before.
All right, I believe that is all the time we have for questions, so I want to thank our speakers for that great presentation and sharing your thoughts with us today. I want to thank our audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.
Thank you.